Okay, the proceed here. Okay, so obviously the title of this is How to Deal with Your BFRB When Life Happens. Or what to do when life and health issues interfere with your recovery. It would be really wonderful if everyone with a BFRB could simply go for treatment and it would go exactly as it's supposed to, according to all the articles in the books that you read out there. Well, it's wrong. Real life doesn't happen like that. In treatment, as in life, things don't always go according to plan. Just another example. How things don't go according to plan. There are many factors that can affect your attempts to recover and which must be taken into account. Within problems, there can be other problems. And these issues can all impact on each other. So as a result, there's no one-size-fits-all when it comes to treatment for BFRBs. A good treatment program must be tailored to fit the uniqueness of each individual and, of course, each individual's situation. BFRB sufferers often bring much more to their disorders than just their habits and behaviors. There may also be present physical ailments, addictions or medications for other problems, family problems, parenting problems, life phase issues, psychiatric disorders, and life stress. So let's start first with physical ailments and the way these can impact. First of all, there are under physical ailments, we have chronic disorders. Those are things like enduring disorders like diabetes or asthma that are present throughout the lifespan. They can usually be controlled, but are not curable, and they can range from mild to severe. Some people also bring with them acute disorders. This refers to disorders which either run a course and then clear up, or that are treatable to the point of being cured. And they can range also from mild to severe. Next, we have the use of legal or illegal drugs. These can include alcohol, marijuana, cocaine, and yes, even things like caffeine, amphetamines, both legal and illegal, antidepressants that may have a stimulant effect. Some can be very stimulating, some can be too stimulating, and also painkillers. Then among the family problems, hope your family doesn't look like this, we have things like family conflict, parental divorce or separation, financial difficulties, a family member's health problems, relocation, problems that come along with blended families sometimes, and possibly loss of a family member. Then we have parenting problems. What occurs under those? We have parents who have poor communication with their children. We have inconsistent or ineffective discipline in households, the loss of a relationship, such as a breakup or divorce, death of a loved one, loss of a job, or these days it could even be prolonged joblessness, educational problems, legal problems, the pressure to succeed, either at school or on a job, and that can even involve children as well as adults, and financial problems. Okay, now any of these factors that we've just run down can disrupt your recovery via generally causing stress, which is then relieved by picking, pulling, or biting, distracting you from being able to follow treatment, because they obviously may take up a lot of your time and emotional and physical energies, causing physical reactions that can directly cause increased BFRB symptoms. They can create situations where you become isolated from sources of support from others. They can cause moods that lead to self-defeating thinking and actions, as well as decreased motivation. Depression is chief among these, and misguided attempts by others to help you with your recovery. Now, for treatment, treatment approach to be effective, it has to be, number one, flexible and adaptable to each sufferer's particular circumstances, because as we said, there's no one-size-fits-all. Comprehensive enough to account for all potential inputs, the ones we've just outlined. Has to be able to help sufferers see how their particular inputs affect their ongoing problems. So they must see the relationship between these things if they're going to deal with them, and how it affects their BFRB. And to be able to teach them the skills necessary to either change or accept each of these inputs, as they say in the AA Serenity Prayer, right? Being able to change the things you can change and accept the things that you can't change, and being able to tell the difference between them. One good treatment model that we've been using in cognitive and behavioral therapy these days is known as the SCAMP model. It takes in all the various inputs that can impact BFRBs. And this is something that other treatment models do not do, and that's what's so unique about this model, and why I like it so much, and why quite a number of other practitioners also follow it. What are the components of it? Well, you can see where the name comes from. These are all the possible inputs. There's sensory, cognitive, affective, motoric, and place or environment. So there can be sensory features in why people pick, pull, or bite. They can be cognitive features, their beliefs, their philosophies, their ideas of things, the things they tell themselves. Affective, in other words, the moods and mood states have to be taken into account. Motoric, in other words, the physical motor actions of pulling, picking, and biting. And place or environment, the places that trigger these behaviors, and also the places where they occur. So all of these taken together have to be dealt with in one balance or another in order to treat people successfully. And by the way, as I note at the bottom, this model was originated by Dr. Charles Mansueto, who's also on the Science Advisory Board of the Trichotillomania Learning Center. So we're going to be focusing on three particular factors in the SCAMP model in terms of how they may be affected by various life problems and events. These are most pertinent to what we've been talking about. Those are the sensory factors, the cognitive factors, and the affective factors. Okay, let's go into a little more detail on these. First of all, let's define these so we all know what we're talking about here. Sensory refers to the various sensory experiences that signal and precede pulling, picking, or biting, as well as feelings of sensory satisfaction occurring during or after that maintain these behaviors. So that's the sensory input. Cognitive includes any thoughts, usually illogical and extreme, which can occur prior to, during, or after the behaviors, and create emotions that lead to BFRBs in the present or future. Affective means emotional states that can lead to BFRBs and which the behaviors help to relieve, at least temporarily. Again, usually depression, anxiety, or anger are the ones that we're most concerned with. So now I'm going to give you half a dozen different scenarios here of some typical cases that I've treated, showing you what the inputs are from these various life factors, and then how they can be treated. You might be able to relate to some of these. I've tried to give you a pretty good assortment of them. Okay, in scenario number one, my patient was a 16-year-old girl, has pulled out all her eyelashes. It's gradually revealed in the course of therapy that she has serious temper control problems that lead to serious family fights that her family contributes to by not handling it well. So she loses her temper, family again loses their tempers and deals with it poorly, which only escalates things. These fights cause her to feel depressed and stressed, which she then tries to relieve by pulling. She would typically go to her room and pull following one of these blowouts that they would periodically have. So what were the inputs in this girl's particular situation? Again, I'm showing you how I break down these cases and how we take them apart and how we deal with the individual components. So we were able to identify, again, as we said, anger control problems, which is involves cognitive and affective factors, family altercations leading to ongoing bad relations between family members, again, cognitive and affective, and depressed mood and anxiety resulting from the family problems, again, cognitive and affective. So these are the inputs that we were able to identify. So what would potential solutions to something like this? Well, in this girl's case in particular, we used cognitive therapy to deal with her anger issues, and I'll tell you a little bit more about cognitive therapy in a moment. Family therapy sessions where we brought everyone in to reconcile family members and to establish rules for getting along. We had to, sort of get them back to seeing, what was good about there being a family and how they could bring out the best in each other and how they could resolve, disappointments or disagreements and things like that, much better than they had been. They all agreed that they didn't do it very well, and they were eager for solutions. They just didn't know what to do, so they just kept repeating the same bad old patterns. And I would also consider referral for medication if the depressed mood seems to have biological components. So what I'm saying here is that if the depression was mostly resulting from home life problems and we resolve those home life problems, we would probably see the depression itself. But we got everything under control, things seem to be working well, then we would look more toward a biological help for this too, because some people have depressions which are aggravated by life events, but which are in fact biological in nature and even may run in their family, in which case medication can be a big help for these things. I said I would tell you a little bit about cognitive therapy, so I'm going to mention it a number of times ongoing here, so let me just run this down quickly. Cognitive therapy is based upon the theory that many emotional disturbances are caused not by other people's actions or by external situations, but rather by the illogical or extreme ways we view and interpret these things. Cognitive therapy attempts to treat disturbed emotions by teaching people how to spot errors in their thinking and how to have emotions that are more moderate and appropriate to whatever situation occurs. This, of course, leads to better coping. There's a very good book, by the way, for anyone who wants to really learn more about cognitive therapy, a very good self-help book. It's called Feeling Good by Dr. David Burns. I use it with my patients a lot in case anybody is thinking of asking that question or is wondering about resources on cognitive therapy. You can get it in paperback all over the place. So very good book, Feeling Good by Dr. David Burns, as I said. Okay, cognitive therapy approaches the treatment of disturbed emotions by teaching people skills in how to learn to better listen to themselves and spot errors in their own thinking, to vigorously challenge these extreme and erroneous beliefs and see their flaws, and then once they've spotted these flaws and errors, to correct them through repeated practice, replace them with more moderate, logical, and provable ideas and better self-talk. So it's recognizing the erroneous thinking, it's challenging it, and then it's replacing it with something that makes more sense and is more logical, that you can actually challenge and see that, yeah, it really is true, it really stands up, and I'm not just saying things that are extreme and that really don't make sense, because that, again, is what causes people to disturb themselves. The idea is to get people to take responsibility for their own emotional lives and also for helping to find solutions to the problems they encounter in everyday life. So again, the overall goal here is coping, and cognitive therapy can be a great help to people with BFRBs. I use it in many of my cases. I'm using it right now in several cases. Okay, so scenario number 2. This was a 25-year-old woman, a business student in graduate school, who works many hours at an internship and also attends classes. She has pulled out 60% of her scalp hair. Her family lives in Arizona, and she doesn't have any close friends on Long Island, where she happened to be residing when I was treating her. She's taken advantage of by her bosses and fellow workers, probably because she's an intern, although that's not always the case, but it was in her case, and finds her work situation very stressful. And she often works in isolation from her coworkers, often a cubicle carrying out the various assignments on her own. So, identifying this woman's inputs. Okay, number one was stress related to heavy school and job schedule, many, many hours, not enough sleep or rest or downtime. So that was an affective, we would identify that as an affective input. Job stress, again, another affective input. Social isolation, which involves like sensory issues, just the sensory issue of being understimulated and isolated, as well as the emotional impact of being isolated. So again, at work and outside of work, both. That's an affective issue. Lack of assertiveness, which is more of a cognitive issue, and isolation at work, as we had said, which is again, a sensory and affective issue. So what do we do about this? Okay, so our solutions were we had her work at learning to manage time most effectively, so she could at least maximize her downtime and her time outside of work by getting the things she had to do done most quickly and effectively. Her studying was a little bit chaotic and not well organized, so we helped her with that, and that made a big difference in reducing stress from all those things, and also from by just allowing her to have more time. We had her make efforts to increase social contacts with fellow employees and in outside venues. She joined an exercise class, met some other women there, which was good for her, and also tried to get involved in some school activities as well to meet people, because again, she was far from home and didn't know anyone. Assertiveness training and cognitive behavioral therapy were used to improve coping skills and self-acceptance. Self-acceptance is another big issue. I'm very keen on that. We try to teach people that they can accept themselves unconditionally, no matter how they're doing in life, or whether they've achieved anything or not, or in spite of anything relating to their appearance. That it's unconditional self-acceptance is what we go for. That you accept yourself as an ordinary, average, mistake-making, imperfect human being, and that accepting that that's okay. Okay, and she did well, by the way. She did very well. Scenario number 3, an 11-year-old, 6th grade boy in a private school who's doing poorly academically, though he was bright. He had pulled out all his eyebrows and eyelashes. It was revealed that he suffers from ADD and began to pull shortly after his family doctor started him on Ritalin, which is a very common thing. I see many kids pulling, picking, and biting triggered right when they began stimulant drugs such as Ritalin or Adderall, those sorts of drugs, which are quite commonly used, as we all know. He finds it difficult to focus in class and quickly gets very bored and understimulated, which of course is part of his ADD, which he then relieves by pulling, which of course only compounded the problem. That distracted him further, actually, because then he got so into his pulling that he didn't really notice what was going on. It was also revealed that he drinks large amounts of caffeinated sodas daily. So as if Ritalin weren't enough, he's taking in even more stimulants in the form of caffeine. So the inputs, number 1, stress resulting from poor school grades and parental criticism, an affective input. Overstimulation due to medication, which of course is a sensory input. Feeling different due to ADD, a cognitive input, these thoughts that, oh, I'm not as good, I'm different, I'm less than the other kids. Stress of understimulation and boredom in school, which is both a sensory and an affective, sensory and affective inputs. And also hypercaffeination, as we said, too much caffeine, which of course affected him on the sensory level by getting him really way up there on top of his Ritalin. So, potential solutions. First of all, we made sure that he was getting proper extra help and tutoring, which a lot of kids with ADD tend to need anyway. Training in better study skills, which the tutors helped him with, and which we also helped him with here in terms of organizing his study materials, keeping better records of things, keeping track and making better schedule for times when he studied, even taking breaks when he studied helped him to stay on track better. Changing medication, we got him on a non-stimulating drug for ADD, Strattera, as I recall, which was not, as I say, was not overstimulating, but which also seemed to work for him, and that was a really good solution. Finding ways to get more stimulation within the school environment with help from school personnel. So he was sometimes allowed to get up, walk around. He was allowed to bring things to school to hold in his hands, to manipulate, to also keep him engaged and to help with the sensory input that he wasn't getting. Being tied down to a desk, is a very understimulating experience, especially if you have ADD, and especially if that's the bulk of your day. And of course, we had him withdraw from all caffeinated beverages. He could still drink, likable things, but they had to not contain caffeine, clearly. And he understood too. He saw that it was getting him too hyper as well, and leading to more of the behaviors that he didn't want to be doing. Okay, and again, these are all cases that we had some very successful conclusions with. Scenario number 4. This is an older person, a 39-year-old pharmacy student, a demanding training program. This is a woman who was changing careers. She has pulled out 70% of her scalp hair and feels very stigmatized, as you can imagine. She was wearing a hairpiece, actually, to cover. She is nearing the end of her school program and cannot find a job. She's already, was looking for entry-level pharmacist jobs and couldn't seem to find any around her area. She lives with her father for financial reasons, and they do not get along. She's left behind a previous career in another city, along with her friends, which was established over the course of many years. So she was really cut loose from all of those things that were her, her support systems. And a long-term unhealthy relationship she had put all her hopes for the future on has just ended very badly. So this was also a great disappointment to her and a great cause of distress. Again, these are all kinds of things that happen to people in real everyday life, although not in the textbooks necessarily. Okay, so what were her inputs? Stress and fatigue from intensive training. In her program, that had a lot of sensory input, sensory triggers there. Depressed mood and anxiety resulting from the effects of hair pulling, which again created some sensory issues and also affective issues. Relationship problems with her father, cognitive input. Again, it was her thinking about her father and his behavior. Financial problems also affecting her on the cognitive level, causing a lot of worry and concern. Social isolation, again, a sensory and affective input. Depressed reaction to the loss of a relationship, cognitive and affective, and facing potential unemployment, again, a cognitive input. So, solutions to this woman's problems. Number 1, we taught her stress management skills, and which included, of course, some of the cognitive things we were talking about. Begin an exercise program. This, I think, was a great stress reliever for her, and I find for many of my patients can be extremely helpful. Use cognitive therapy to improve relationship with father and to deal with relationship breakup, which we did. And I guess she ultimately concluded she could get along with her father even if they didn't always agree or see eye to eye on everything, but she did learn to appreciate her relationship with him better and the support that he was giving her while she was in school. And also, cognitive therapy, I think, helped her to challenge some of the ideas about her relationship, that she couldn't possibly carry on without this person or live without them. And in fact, she even concluded, after we examined the relationship in detail, that she was probably better off without this person because it turned out the relationship wasn't the healthiest kind of relationship for her. We had to get financial counseling to deal with, debt and school expenses and other issues. We had her take steps to increase social contacts. Again, a lot of people with BFRBs can become isolated and cut off from other people due to the input also of shame and embarrassment relating to appearance problems. Also worked on job finding skills and generating options for finding jobs. We had her get some interviewing coaching, learning how to do that. Had someone help with her resume, someone who was kind of expert on that. Had her really work at not just looking for physical jobs themselves, but how to actually get a job and get accepted when you finally do find one. And we also had her look somewhat outside the area where she had been looking, and she was, in fact, able to find a job. She just had to look a little further than she had. She was kind of limiting herself a bit too much. But again, these were all ways in which we came at this. I'm hoping that by seeing these things, it'll give you some idea of how multifaceted these problems are and how many different inputs there are and how they have to be dealt with. And it's not just getting a single technique or a single tip is going to solve this problem. These are complex problems, and they involve and need complex solutions. Scenario number 5. A 59-year-old woman who works as a teacher's aide in a public school and has 2 grown children in college whom she misses, sort of what's commonly referred to as empty nest syndrome. She's pulled out all the hair from the crown of her head and feels defective. It is revealed that she has suffered from a serious and unremitting depression for the last 10 years. She had sought treatment for it, but no one had been able to help it. She's very unassertive and is treated badly at work by her superiors and outside of work by acquaintances. She put up with a lot of bad treatment by people that she didn't need to, and hung on to a lot of so-called friends who really weren't what you would call friends. Her depressed mood has cut her off from all her friends, or especially her real friends, and she's become very isolated. Finally, her husband is very emotionally detached and has recently retired, and I think him being around all the time kind of has made her more aware of just how detached he was as he went off, to pursue his own interests and didn't really pay an awful lot of attention to her or what she was going through. So she felt not only that she had these problems, but alone with him and couldn't to her spouse for support and help and encouragement. So what were the inputs? Number 1, depressed mood due to empty nest, an affective input. Stigmatization due to appearance, having lost a good deal of the hair on the crown of her head, cognitive input. Chronic long-standing depression, an affective input. Frustration and anxiety over lack of help for depression. She tried, as said, for many years and nobody could seem to help her. Again, cognitive and affective. A lack of assertiveness, cognitive issue. Social isolation, which was seen more of a sensory issue. And finally, lack of intimacy and support from her spouse, which involved both cognitive and affective issues as part of this input. So what do? Okay, number 1, cognitive behavioral therapy to help cope with life change or children, moving on with their lives, and the stigmatization. Both needed a pretty good intervention for that. She got referred to a better specialist for medication for depression, and actually I can tell you, find a medication which was, I think, almost the only one she hadn't tried yet, and she was convinced it wouldn't work, but she tried it, and sure enough, it helped the depression tremendously, and that took a big load off of her mind, and it made our job an awful lot easier. Couples therapy for relationship issues sent her and her husband to a good couples therapist who, kind of helped them sort out a lot of things, and got the husband to see things that he could be doing to make life easier for her. Increase in social activities, had her join some groups. She had some hobbies and interests that she enjoyed doing, so we got her to seek out other people who attended groups and where they did these things together, and really helped her quite a bit. And assertiveness training, which finally got her to stand up to her boss, not to mention a couple of, as we said, the so-called friends, and some of them she no longer saw, but then I think that actually made her life better because these were toxic relationships. Okay, our last scenario, number 6. A 15-year-old boy in 10th grade. He pulled out his eyelashes. He's an honor student taking all AP or advanced placement classes, which generate great amounts of homework. I mean, hours. He'd be up until midnight working, and which put him under great pressure. He's also under great pressure to succeed by his parents. They had very high hopes for him, and never hesitated to let him know about it, and sort of implied, how disappointed they would be if he couldn't live up to those expectations. He has no free time to unwind, and I mean none, or activities he does just for fun. So a pretty bleak life for somebody who's only 15, all work and no play, as they say. So the inputs were extreme pressure to succeed on the part of the parents and the patient, because they were not only pressuring him, he had absorbed their message and was pressuring himself every day. He probably didn't need much pressure from them because he was quite capable of pressuring himself. A course load that is possibly unrealistic and excessive, sensory and affective input, and finally lack of downtime to relieve stress and promote relaxation and diversion. He had none of these things. So we identified that these were the big three in this particular case. So what did we do? Number one, there was therapy with the parents to encourage them to take the pressure off. We showed them how what they were doing was actually counterproductive and wouldn't result in their son being more successful, but might in fact result in a burnout. We got them to back off. They did. I think they recognized that they were overdoing it. Cognitive therapy to help moderate patients' perfectionistic demands upon himself and worries about disappointing his parents. We had to have him change some of his ideas about the because clearly they were not realistic ideas, just as the parents' ideas had not been realistic, and we had to get him to see that his doing this to himself was no better than his parents doing this to him. Activities that had to do with academics, had him go for some sports activities that were available at his school that he really enjoyed and had always wanted to do but never felt he had the time to do. So we got him to do that. I'm sorry, I also skipped over conferring with the school and parents to see if class load can be modified. We, in fact, did have a couple of courses that he was struggling with, a couple of the advanced placement courses, sort of stepped down to just being regular courses, which he did well in, and he was more than able to do well in them. It's just that they didn't. It took a couple of hours of homework away from him every day, which then enabled him to find some other activities and also have a little time to himself. Okay, so that covers our basic talk. I guess now we're ready to discuss any questions you have. There's my I can be reached through my my website. You can email me through that. There's the web address of it. So okay, I guess we're finished.
Okay, well, thank you so much, Fred. I am going to my webcam didn't seem to be working very well, so I'm just going to hope that this audio is okay. All right, so the first question for you is from Jill. She asks, as we're recovering, should we try to avoid other major changes in our life when possible? Can you hear me?
Yeah, so the volume's a little bit low. I don't know if you can turn it up.
Okay. All right. So Jill is asking, is that better?
Yeah.
Okay. Jill is asking, as we are recovering, should we try to avoid other major changes in our life when possible?
I think that a person's everyday life still has to continue no matter what. I think you can work on these things and still maintain a normal life. I think the real goal here is to just acquire the skills that allow you to cope with these things. I don't think you should curtail your life. I think, in fact, that might actually make a person feel that the BFRB is having an even greater impact on them and might make them feel worse, actually. So no, I think you should try to live your everyday life as normally as you possibly can, and if you need help with it, get that help. But do forge ahead.
Okay. She followed up with more of a comment, but this kind of topic is one that comes up a lot for us. She mentioned that her skin picking became worse after being prescribed Adderall for daytime sleepiness.
Yeah, we see this quite a bit. The overstimulation caused by a lot of different drugs. It could be stimulant drugs, even certain antidepressants. I've had people on Paxil and Prozac get overstimulated by those, which even if you didn't have a BFRB, you would probably want to talk to your physician about that and see what they could do about changing you to something that won't do that. If a person has excessive daytime sleepiness, there can be a lot of causes. One of the things we look to rule out sometimes is sleep apnea that some people have, and that can be quite serious. So that should always be looked into, and I often send people for sleep evaluations if we suspect that sleep apnea might be present. But if it isn't, and there may be other reasons, the person's not getting sufficient sleep, there could be physical conditions that are causing fatigue. So rather than just treat it with stimulants, I would certainly try to see if there's something that we could be treating the cause, not just the tiredness, basically. But yeah, you have to be very careful with stimulants. Even caffeine and soda, as I've said, or coffee or tea can be very detrimental to some people.
Well, that segues very well to our next question, which is from Anila. Uh, she asks that she's recently started drinking coffee because she needed a boost of energy. Do you have any suggestions for replacements that your clients may have found that help provide energy without caffeine?
Yeah. Number one, I think getting exercise can boost a person's energy levels. I think eating properly, of course, is very important as well. A lot of people's diets, especially like carbohydrate-heavy diets, can lead to fatigue. It definitely affects mood. And most basic of all is just getting enough sleep. We have so many things to do these days. I have patients who just stay up late at night, texting their friends or watching things online or TV or things like that. And these things really do take away from some people's sleep. Now, I don't know this individual in particular, but you would want to make a pretty careful inventory of your life and try to rule out all the things that could also be causing a problem like that. I myself gave up caffeine about 15 years ago just because I felt I was relying on it too much, and I found that I actually got more sleep as a result of getting off that, and I had greater energy. Also changing your diet. Some people suffer from hypoglycemia, and just by changing the number of meals they eat during the day and what they eat can also make a great difference to energy levels. So there's a lot of potential inputs for problems like fatigue, and you really have to examine them very carefully.
Mm-hmm. Your next question is from Jessica, and she asks, she's asking for help for suggested ways to help stay in the present moment. She says, I think about the past and the future more than the present, and that's when my skin touching comes in, and she began to pick 2 years ago and has been pick free recently, but she catches herself touching her skin when thinking about things and not being in the present moment. She does do some yoga and meditation, but it still seems challenging to just stay in the present moment.
Okay, it's funny. The first thing I was going to suggest was yoga and meditation. Actually, I would suggest, in addition to that, this is where cognitive therapy can be very helpful. To get a person to sort of examine some of their ideas about the past and to challenge and change some of them. I think cognitive therapy can be very effective. A lot of people are walking around with all kinds of regrets and upsets and memories and things that they're not dealing well with, whereas I think cognitive therapy can help you put these things into perspective. And if you put that together with the meditation and the yoga, that this I think that could be a very good combination.
Okay, thank you. Siri asks, do you have any suggestions regarding trichotillomania and trichophasia in children? My 10-year-old just had her second bezoar surgery in 22 months. She's had trich all her life. She's in cognitive behavioral therapy and has been for years, and she takes Prozac.
Well, I think what we usually look for in situations like that, and we take trichophagia very seriously because it obviously can have very serious physical implications for people who don't know what that is. That means people who not only pull hair but who swallow it as well, and this can cause what are called trichobezoars, which are like intestinal blockages, which can be fatal, obviously, and require surgery to remove. Luckily, not everybody does that, but especially if a person swallows long hairs, it can especially cause that. What we always look for, one of the things we look for, obviously there's a very strong sensory aspect to swallowing hair. I mean, it has a lot of texture. The mouth is an area, very rich in sensory nerves. I usually try to find substitutes. You can't just take these things away from people and leave them with nothing. I would try to find things that the child could chew on or eat that would be easily digestible, but that might have a kind of texture that appeals to her. Whether it would be things like pasta, like long strands of spaghetti, or spaghetti squash, or string cheese, things that can be pulled into long thin strips, or things like that. She might find, and you might have to experiment with a lot of different things because you have to always, there's no one thing that works for everyone. But I would try to find some substitute things that could be eaten, chewed, swallowed, etc., that she might find an acceptable substitute. Because if you don't, she'll just keep turning back to hair, and obviously we don't want her to do that.
Okay. Sonia,
I hope that answers the question.
thanks. Sonia just had joined late and asked what affective input means. Affective input, meaning emotional inputs. Is that basically what you meant, Fred?
I'm sorry, it got garbled a little bit. I couldn't quite hear what you said.
Oh, I'm sorry. I'm so sorry that we're having these audio troubles. Um, Affective input.
Now I'm not hearing anything.
Oh no.
Yeah, I'm not hearing you.
Okay, sorry, Fred. Hold on, let me see what I can do. Is that better? Can you hear me now?
I can't hear what you're saying.
Oh dear.
Yeah, Jen, I can't hear you.
Okay, okay. I'm trying to deal with it. You can't hear me, so you don't hear me.
The audio's
Okay, all right.
yes, it was sort of going in and out. I couldn't hear most of what you said. If you could repeat that, please.
Sure, sorry. It does seem to be going in and out, and I just apologize. I'm not quite sure if there's a problem with my web connection or not.
Yes.
Okay, so the question was, what does effective input mean?
I'm sorry, what was it about affective input?
Yeah, what is the definition?
Yeah.
No? What are you under, Leslie? Because maybe I could log on as you.
I'm just in the
There you are. Oh.
You make me an organizer.
My computer's just not. Okay. All right. Okay, hold on. Are you hearing me now at all? Here, I'm going to try and move this around. Is it because the door is closed? All right. Hello? Can you hear me at all? No? Oh, dear. Hello? Hello? Can you hear me? Oh, dear. Maybe I should try to. Maybe
come over here.
It's not even letting me do that for some reason. Maybe if I call in. Do you think it would let me call in?
Except that her phone's unplugged.
Oh. Well, it's 10 minutes out. I don't know what to do at this point. We're going to lose people pretty fast. Okay. There. Would you like to dial a...
Jen?
Hi, Fred. Can you hear me? Can you hear me at all?
Yeah, now I can.
Okay, I'm gonna try.
Yes, I can hear you.
Yeah. Okay, let's just see if this works. I'm sorry, I'm moving the computer around trying to figure it out. Okay, so the definition of affective input is emotional input. Is that correct?
Yes.
Okay.
The effect of your emotions upon as triggers and influences upon your behaviors.
Okay. All right. Let's see if we can get to some other questions. Have you seen any input to excessive sugar intake impacting BFRBs?
Not per se. I would say again, that if a person has very high sugar intake, it's probably evidence that they're just not eating a very good diet. In which case, I'd want to balance that out. I think a person should, make sure they're getting a lot of, fresh fruits and vegetables, getting enough fiber in their diets, all sorts of things that go into making up a proper diet. So, I think too much of anything is no good for a person, quite frankly. So it should balance is the key to health.
Any suggestions for people who work from home or people who are on the computer all day?
Yes, I would say taking frequent breaks, getting up, moving around, taking exercise breaks, doing anything to get yourself out of that environment. Again, sitting in front of a computer and being physically immobilized like that a good part of the day can be very understimulating. And I know plenty of people who pick and pull in front of the computer. It can be a big trigger for a lot of folks. So anything where you're tied down, where you're physically immobilized. We see that a lot with kids, just sitting at their desks in school all day. But also I have people at their desks at work or in cubicles or even working from home. So I would, at home actually, you probably have more flexibility for things like that. So I would definitely get up, move around, take breaks, and do all of those things. And that can certainly help. Also, at home you can keep more things, more stimulation substitutes around, which you might not be able to bring to work, which could also be very helpful. So have those things, handy, things that can substitute, things you can do with your hands, your mouth, etc. When you're not only working, but that would help as reminders and also give you some alternative to the behaviors themselves.
Okay. Um, the next question is, do you have any suggestions for assertiveness training for a young teenager?
Yeah, I think, it should be combined with cognitive therapy, because usually the reasons that people are not terribly assertive are some, mistaken beliefs that they may have about themselves or what their rights are as people. And I think, in cognitive therapy you can be taught these things. There are a lot of good books out actually on assertiveness as well. There's a book that was out for many years. It's probably still available. It's called Your Perfect Right, and there's a lot of books, and I'm sure there's probably, I haven't checked the literature lately, but I'm sure there's a lot of books for teens out there. Usually when I see people who are non-assertive, I also look for, problems relating to social anxiety, because that sort of seems to go along with it in many cases. So that might be something else that might need to be worked on with cognitive and behavioral therapy, because that requires behavioral therapy as well. But it's quite treatable in people of all ages, I think, and there's a lot of good materials, and there's a lot of people who specialize in it nowadays. You just got to find them, but there is a lot of good help for that, and I would look at books for teens on that. I would not be surprised if there were quite a few. I know there's a lot of books on bullying these days that might even encompass some of that as well.
Mm-hmm. Oh, and Sherry Vavricek recently wrote a book called Compassionate Assertiveness. It's not necessarily directed
Yes,
at youth,
Compassionate Assertive,
but
that's correct. Yes,
yeah,
Sherry
yeah.
Vavricek's book is an excellent book. I
Mm-hmm.
definitely recommend it. I like that very much.
Mm-hmm. Um, a question from Bo. He asks, "My daughter's 15 years old and she pulls her hair and is not good at her time and homework management. Is there any medication available?"
Uh, Well, there's no medication for time and homework management. I would say if she happens to have ADD, certainly you could investigate that. There are some non-stimulating alternatives if she in fact does have ADD. If it's just a management issue, then I think working with either a learning disability specialist, if you want to find one of those, or anybody who works a lot with ADD usually has a lot of know-how and a lot of good information. There's even quite a few good books out these days that you can get a lot of good information on for people with ADD that deal with things like study skills and time management, organization, which all that executive functioning stuff, which is always very problematical in those kind of disorders. Again, I would be very careful with medications because they can be a mixed blessing. You can get these people are generally understimulated, but you can get too much of a good thing, and then you've only worsened the problem. What was just minor pulling or picking before could become quite serious as a result. So a lot of physicians don't know a lot about BFRB, so often they don't take that into account when they prescribe these things.
Right. Okay. Um, Greg asks, do you ever use HRT, habit reversal training, in combination with the SCAMP model, or how do those two work together?
Yeah, well, the SCAMP model basically, by breaking down all the various inputs, it leaves room within there for any technique that will address that particular input. So yeah, habit reversal training we would use as a technique within the SCAMP model, definitely.
Mhm.
I find that it takes a lot of work and is very effort intensive, so you got to really be very dedicated if you want to make it work. In fact, I find that younger children we don't generally do it with because they're just not up for the kind of discipline and work that it involves. But sure, I would use that as a technique. It's a proven technique, and we definitely would include it as one of many things that we would use to treat all those various inputs.
Um, Great. And well, that segues well to Carrie's question. She says, "My daughter's 19 and has gone through therapies and medications. She's out of school and working a full-time job. She's happy but shows no interest in stopping pulling. She's working to afford the wigs and she pulls from them. What should a parent do?"
Boy, that's I guess the thing I always tell people is you can't want someone to get better more than they do. Uh, they say frustration is the mother of change. I guess in this particular case, because she can get wigs, that therefore she doesn't really have to deal with the problem, and she may not be ready to either. I guess all you can do sometimes is, you might find an expert or someone who really knows how to treat it. Maybe I don't know if she's had real expert help up until now. Maybe she has. if she has and she's still not taking advantage of it, then I guess all you can do is just let the person know that you're there for them if they should ever need help or want your assistance in getting help. But beyond that, there's not an awful lot you can do, really, especially if this is an adult. Now, we sometimes have to respect other adults' wishes, even if we don't always agree with them. I can't say it's the best solution, but sometimes you really don't have a choice, because the only person who can control their pulling or picking is the person themselves. And sometimes just getting on their case about it, or telling them that they must do something about it, it's not going to accomplish anything. It might just alienate them, actually, and it might turn them off to the idea of getting help at all. So maybe she just needs a break from all of that treatment that she's had, and needs time to just kind of live with it a while before she's ready to dive back into treatment again.
Mm-hmm. Yeah, we hear at the office, it's quite a common situation to be in, and it's obviously a difficult one emotionally for the parent. I do know from other parents that sometimes what they do is just make sure the child or the adult child knows that the parent is available to help them find resources and help when they're ready.
Exactly.
Yeah.
Exactly. Yeah. That's sometimes that's the best that you can do. I have kids who come here also with their parents, and they tell me they don't want any part of therapy and they don't want to do it, and I tell them that it's okay, that they don't have to do that right now. That but if they should ever want to come back, I'll be happy to work with them, and I'd rather just end things on a good note like that and just leave them with a good feeling, so that they might actually come back if they change their minds. And that's about the best, as I say, that you can do, is just leave the door open.
Okay. We'll have time for 2 more questions, and one is from Anila. She asks, are positive affirmations an effective tool?
I have a saying, everything works for somebody, but nothing works for everybody. So I would say if they work for you, then absolutely. I use a lot of sayings in my work, sort of these little things that stick in people's minds, that they can call up in a moment and remind themselves with, and act as reminders and act as motivators. And sure, I think any of that is good. As I say, some people find things like that indispensable. They've used them for years, and then there's other people who say, well, that really doesn't speak to me very well. So, but if it works for you, absolutely, by all means. I even posted some sayings on my website, actually. I have a whole collection of quotations. I hope sometimes people will find some of them inspirational. And I have a section there just for people with BFRBs. If anybody's interested, you can look them up.
Terrific. Finally, Amy asks, I've had tricks since age 13. I now see my daughter, who's 11, starting to play with her hair, singling out hairs and following them down the shaft. I'm concerned that she may start pulling too.
Okay. We sort of walk a fine line with things like this, because on the one hand, it might turn out to be nothing, and just by being sensitized to the problem, we don't want to jump the gun and get her all worried and anxious that, am I going to have this problem? Because, we're always taking the chance that the stress that we could generate in them could actually lead to triggering some pulling by some chance. I'm not saying that's a definite, certainly not. But I think that all you can do is just watch and wait, basically. I mean, until a person's actually doing it. If you see them starting to actually pull, or they mention it or something, then yeah, you would want to get an intervention going, as quickly as possible before things go on for very long. But if they're not actually doing it, I mean, some people just get sensory value from just stroking their hair or running their fingers through it, and it never really goes beyond that. You see people do that in public all the time. When you're stopped at a light very often, behind other people in their cars, you can often see people running their fingers through their hair or touching it. It's certainly a very common thing. It's just, if it doesn't go to the stage of pulling, then obviously they can do it throughout their lives, and it would never be an issue. So, as I say, it's kind of a tricky thing to manage.
Does it make any sense? I have my own kids, so I'm very interested in this question.
Sure.
As trick runs in my family. My mom, my sister, and I all have it, and I have 2 daughters now. Does it make any sense to try and offer other sensory options to a child who's starting to play with their hair, like a fiddle toy or a soft blanket or something like that?
Yeah, if they're open to it. I mean, if they just kind of push it away and don't want any part of it, then okay, you can't force it.
Right.
on them. One of my old professors used to say that you could sum up all of child psychology in one word, and that was readiness.
Mm.
That people and children especially only do things when they're ready to do them. So, again, you can always try these things, but if don't force the issue if you see that it's not the right time or there's no
Mhm.
interest there. I think you can do more harm than good sometimes by trying to really lean on somebody that
Mhm.
way. So you have to take a very measured approach.
Mhm. Oh, thank you. Well, okay. And thank you very much, Fred. This was really wonderful. Thanks to everybody, and thank you for your patience in with the audio problems. I'm sorry that they occurred. Um, and please stay tuned. We haven't yet scheduled our 2014 webinars, but we plan to bring you many more wonderful webinars in the year ahead. And if you are not already members of TLC, I just urge you to join, make a donation, become a member. It supports all the work that we do, and it also gets you a lot of information. We do send members a big packet, a comprehensive disc full of articles that should be really useful to you, and a newsletter that's really jam-packed with good articles. It's not just fluff. And so anyway, I urge you to join and support this cause if you are not already supporters. And if you are, thank you so much for that. And have a wonderful day. Thanks.